Okay, we should be live. And as we tend to do, let's jump right into it so we can make the most of this hour. And I think it's going to be a great one. Logistics, as always, we are recording this, and the recording in both podcast and video form will be posted to the Cyft website. Everyone is encouraged to send questions throughout the conversation via the Q&A button. And let's see if I can advance the screen. And welcome back, everyone, to the next installment of the Analytics and Palliative Care Journal Club. I just want to take a minute to say thank you to everyone for not just joining, but sharing. When myself and Amy and Martha, Dana, Janet, and Caitlin had this idea to put together a journal club that combined analytics and palliative care, we understandably thought that this would be a rather niche topic. And yet we've seen the attendance grow from in the tens to in the hundreds. And now for this particular episode, no doubt because of our esteemed guest, we're over that number too. We're now well over 400 registered to listen to these, I think, critically important topics. So thank you to everyone for caring and for sharing the fact that we're doing this. It's been really flattering and very rewarding to see it grow. Today's episode, we are learning from Brad on lessons learned from 10 years of value-based care models. And of course, Brad Smith, for anyone who does not know him, was the former founder of Aspire Health, which was a palliative care company, then became the director of CMMI, the Center for Medicare and Medicaid Innovation, also referred to here as the CMS Innovation Center. And he quite recently published an article in the New England Journal of Medicine, really wrapping up 10 years of lessons learned, progress in lessons learned in value-based care. And really, if you haven't had the chance to read it yet, I think it's fantastic and insightful. And Brad, thank you so much for taking the time to share your thoughts on where we've been and where we're going in value-based care. It's much appreciated.
Thanks for having me. I'm excited to be here.
So as we tend to do, we start with a recap of the article, why we think it's important, the main points that the author made, and then we open it up for discussion. And really, every time I think of value-based care, I think of this quote from Dr. Paul Batalden, who is a pretty well-known healthcare quality improvement person. And he said, every system is perfectly designed to get the results it gets. And in the US, we have designed a fee-for-service healthcare system. And so we reward volume and we reward complexity. As a result, in the US, we spend more as a percent of GDP and even in total than any other nation in the world. But we don't get the best bang for our buck. And depending on the study that you read, the US does not do well in terms of the outcomes we achieve. And that is because we tend to invest on volume and complexity, and you can see it in where we invest. We invest more money in practices and physician types that tend to be involved in the hospital, delivering acute care at its most complex, versus if you look at the bottom of this list, people who deliver more preventative care, family medicine, internal medicine, pediatrics, et cetera. And this is important for those of us that are focused on palliative care, which is preventative in nature. So CMMI was formed to reduce program expenditures while preserving or enhancing the quality of care. And in his article, he reviews what we've learned in the 10 years of really leading the charge in new value-based care models that shift our incentive from paying just for the volume of care, but to now paying for the quality of care and basically aligning incentives for patients to stay out of the hospital, at home, and healthy. And in those 10 years, Brad points out, 54 models have been launched. More than 1 million providers have participated. 26 million patients have been affected in value-based care models. And today, more than 40% of Medicare fee-for-service, 30% of commercial, and 25% of Medicaid is delivered under some form of value-based care model in one of these 54 models that is launched. Now, he points out that although there's been tremendous progress, there are reasons to be reflective and to think carefully about how we can get better. And these are two really important points and quotes. Quote, the vast majority of the center's models have not saved money, with several on pace to lose billions. And most don't show, quote, significant improvements in quality. And from there, he begins to outline some of the higher categories of lessons learned, and he paints some fantastic examples of where the program can improve. The first area that he identifies is voluntary participation. Now, for good reason, you launch new programs under voluntary participation because you're trying to grow momentum, you're trying to learn from this, you're trying to inspire providers to participate. 50 of the 54 models were voluntary, but what we find is participants drop when they lose money. And upfront payments are very popular among participants, and they boost participation in the programs, but if you look at the data, they do lead to greater losses for the center. And therein lies the challenge, the paradox in not just value-based models, but in all of healthcare. When the center loses money, in other words, when it costs more to the taxpayers to deliver this care, the providers make money. When the providers make more money, taxpayers lose money. And striking that balance, hitting that sort of win-win is the challenge of value-based care and the challenge of CMMI. The second area is benchmarking. Benchmarking is important because it is, in effect, setting the budget. It is the goal for any value-based care model. The challenge with setting the goal in advance of participating in the program or before you begin to deliver the care is that you can do it one of two ways, retrospectively or prospectively. In either case, it can be difficult to predict. And changes in practice or even the way we assign codes can have dramatic effect on the budget and the resulting performance. And he gives great examples of when, for example, in the comprehensive joint replacement program, the use of SNFs went way down just as part of a change in practice patterns. Suddenly the budget, which was based on historical, went way out of whack and the program ended up costing way more. So there's a few great examples of how these seemingly subtle things can lead to millions, if not billions of dollars in losses. Also, adverse selection. When you set a budget based on a regional or a national average, what you're doing in effect is creating incentive for the worst performers to get involved because they have the greatest room for improvement, and that obviously is not ideal. Next is quality, and in the article he identifies that it's hard to compare cases versus controls because in the case of participants, you can ask them to capture additional information into registries or to submit information that you can use to measure whether or not they're doing a good job, particularly around quality. But for the control group who's not participating, the only data CMMI has access to is claims data. And if you've been involved in any sort of analysis based on claims alone, you know its limitations. Oftentimes, what they evaluate the program on and how people get paid don't overlap, which leads to issues, and he gives an example of that. Next area is operating capabilities. And when I read this, I thought, another word for this is technical difficulties. The systems that CMS and CMMI uses to run these programs were not necessarily designed to do that. And he gives several examples of where the information systems they use to run these programs, there were errors in using that information to line up to determine who was attributed or not to a program, or even to assign which program it was. And those mistakes cost hundreds of millions of dollars in the running of these value-based programs. So having laid out some of the challenging areas, he then follows up with the path forward. And I would say when a CMMI director lays out a path forward, anyone that has any interest in value-based care and where this is heading should pay very close attention. And I thought it was fantastic that he took the time to lend his opinion to where we need to go as a nation when it comes to value-based care. This quote's important. He suggests we launch new models that move large portions of risk to providers in two-sided risk arrangements. So whereas in the past, many of us may know things like ACOs to be largely shared savings only, he is advocating that both upside and downside risk be used with upfront discounts in return for giving participants greater flexibility and upside risk. And I know that I'm adding my own commentary here, but when I think of palliative care and where this is literally coming to be right now is under direct contracting, even more specifically under the high needs track. Basically, they're giving tremendous flexibility, a lot of upside and downside risk, and in some sense, making the provider a little bit more like the payer. Second, move faster to change or terminate models that aren't reducing cost or improving quality. That makes perfect sense. Third, set more accurate benchmarks. at a minimum, test a benchmark against historical data. And what I found most insightful, if not surprising, was the fact that he wrote that may suggest that they haven't always done that in the past. Use retrospective data to create guardrails on prospective models. So when you are creating a budget based on what is likely to happen, use what has happened to sort of keep things in check, or at least to keep an eye on whether or not things are going the way we anticipated. This is very interesting. If risk of adverse selection is high and participation is likely to be low, consider making more models mandatory. For me, what jumped out is, for example, VBID, which did not have tremendous participation, but has really tremendous repercussion. There are models that he is suggesting we don't ask folks to volunteer for, and that is really important. Then better align quality measures. We should not be evaluating a program on one set of metrics, but paying out the participants on a different set of metrics. But he also suggests making the metrics more consistent across the many programs that they administer, and even beyond the programs that they administer. One of the things that CMMI has done is inspire commercial payers to launch value-based programs, and they can introduce a barrage of new metrics, which complicates things. And finally, and I am obviously a huge fan of this, invest in data sharing, real-time data access via application programming interfaces, which basically just means give folks the opportunity to have access to more data faster, so that we're not looking at data that's 3 months old to decide whether or not we're doing a great job. So that concludes the overview of the article. And now we will hand this over to Dana, Brad, and the rest of the esteemed panel to continue the conversation.
Thanks so much, Len. And thank you, Brad, for joining us today. I wanted to start with a question to you about the goal of CMMI. We hear that its main goal is to reduce total cost of care and improve quality. And I wonder if you could help us understand a little bit more about why value-based care is so important.
Yeah, absolutely. And one of the things that was fun when I took this CMI job is I got to catch up with a lot of the folks who were there in the Obama administration who actually put together the job for CMMI. And the federal government for a long time has run small research programs on different kinds of interventions, but they tended to be pretty small. It was hard to get them funded. It was hard to have the flexibility to implement them at scale. So one of the ideas that Nancy and DeParle and many of the folks who put the ACA together had was really to take this type of function that did exist in the federal government, but really give it more funding, give it more resources, really with this belief, which I think probably all of us share, that we need to move in aggregate from kind of a system that pays for fee for service to one that pays for value. And so really what they did is they created this large budget. It's $10 billion every 10 years. We're in the second cycle, so it's like a $20 billion, budget that will be spent, here, 5 or 6 years from now. And it gave a lot of flexibility to waive Medicare and Medicaid payment rules without having to go through Congress. Probably most importantly, it allowed the Secretary of HHS to be able to take models that were successful, and I'll come back to those definitions here in a second, and be able to scale those models without having to go through Congress as well. So, I think really what they believed they were creating, and in many ways they did, was kind of this pathway to truly test things, and then if they worked, to really be able to scale them without having barriers that would get in the way. And so to do that, they laid out, the goals by which you would measure the success of these pilots and the success that was really the trigger to allow them to expand. One of those was cost and reducing cost. And I think, with the increasing healthcare costs we see across the country, this was obviously a driving factor. And I think most of it was, at least on the surface, believe that the reason we're trying to move from fee for service to value is we believe that you can deliver at least the same quality, if not higher quality care at a lower cost. I think we're finding, as we'll talk more about, it turns out that's a little bit harder to do than maybe we thought. But I think that was a core underlying thesis, is to help address the Medicare trust fund issues that are building. And then the number two is obviously obviously improving quality and at a minimum, making sure we maintain quality while we reduce costs is also critically important. As I'm sure we'll get into later, measuring quality for lots of reasons turns out to be a little bit harder than measuring costs. Measuring costs is also hard, but quality is even harder. But like these were the clear goals that kind of they set out. And I think, for the most part, they're the things that everybody's been aiming for. I think, and we'll get into this more in different moments, things like participation in programs, things like stakeholder reactions also have to be balanced against these more tangible goals of cost and quality. But I think a lot of the efforts have really been focused around, trying to test if we can reduce costs and improve quality.
Yeah. And over the past decade, you talk about the 54 or so models that have been launched, but only 5 had reduced cost, even though $2 billion was spent, 1 million providers participated, 26 million patients enrolled. Can you talk about a few models that actually did work and why?
Yeah, for sure. And maybe I'll just give a little bit of context for how the center, I think, has evolved over time and where we are, and then I'll hit on the ones that saved. But when you set up something new like this, the first thing you want to make sure it does is that people participate, right? Because if you don't have people participating in the models, or people don't want to participate, it's not going to be successful. And so I give Rick and Patrick and all the folks who were there early like a ton of credit for getting so much participation, in these models. The other thing, we might get into this more later, is it takes a long time to build data on these models, at least the way it currently operates today. So normally it takes a year or two to design a model, then you roll it out. It takes 2 or 3 years to get data. It maybe takes a year or two. So I mean, the cycle from starting an idea to having reliable data, there's a lot of things we're doing, or that we were doing, to try to shorten that. But I mean, today it could be like 5 to 7 years from start to finish. And so, in many ways, I benefited from coming in at year 10 when, there had been a lot of things that had been going for an amount of time, and there was enough data there. So, as you mentioned, part of what I was asked to do is kind of go through the portfolio and kind of see how we're doing 10 years in. And 5 of the models saved money at a statistically significant level. There were a few that were kind of in the neutral bucket. And I'm not sure that there's a full overwhelming reason these 5 save money, but I think there's a few themes. So 2 of them have to do with pricing. So one was the non-emergent ambulance transport model. This was, for lack of a better word, a utilization management model, where you had to go through certain processes to be able to manage or to have an ambulance ride to a non-emergent appointment. Probably not surprisingly to any of us, saves money. It's a pretty, direct mechanism to do that. And we didn't see any changes in quality, which is obviously what you're worried about in like a model. The other model that was really based on kind of payment rates was the Maryland all-payer model. As some of you guys may know, for like these really historical reasons, fee-for-service providers in Maryland have always been paid more than the rest of the country. It's a really complicated kind of history. And essentially what happened was CMS kind of negotiated, as part of this model, a discount to not get them back to normal, but to start moving them back closer to normal. And the state agreed to it because they were afraid otherwise they'd have to go all the way back to normal, basically. So it was essentially like a price negotiation with the state of Maryland. So again, and price negotiations are probably pretty obvious ways to save money, and you see that in 2 of these. I would say in 3 of the others, I think they're probably more the traditional kind of value-based models that folks think of. One was a model called AIM, which provided upfront payments primarily to smaller providers, including many rural hospitals, to move into the MSSP program. Another one was the Pioneer ACO program, which was the first version of the ACO program. Again, the folks who were early adopters tended to be some of the leaders in their field and the most investment around doing these kind of things. And then the 5th one was this home health value-based purchasing that we actually expanded while I was there. It was a mix of the home health quality metrics, and it turned out that hitting those quality metrics reduced hospitalizations and readmissions quite a bit. So, I think those latter 3 probably are more in kind of the frame of what we all think about value-based care models. But I think it's interesting noting that, we've probably only done 2 pricing or models, or we did 3. One of them was neutral, and the other 2, had pretty significant savings attached. So I think just as we think about how we achieve different goals, it's important to kind of, see that balance there.
Makes sense. And as you think about the programs that didn't save money, the 49 that didn't work to save money, what do you think the reason is they didn't work to do that?
They're all different, but what I'd say kind of like big picture is, I'm still optimistic about value-based care. And I think what we've learned is that the technical details on these things matter a tremendous amount. And, when you're talking about 1 or 2 or 3% of savings or losses, how you do some of these technical things just really matter. And I think the truth is that, over 10 years, we've learned a lot about how to do that well. And so I'll mention kind of a couple of the issues, but again, I think they're kind of technical and design in nature, not kind of philosophical in nature. One is how much upfront payments do you pay? So in many of these models, the hope is that by doing more of certain things, you get less of other things, right? It's the core idea, for example, palliative care. And I think what we find is that how much money you pay to do those more things, the success of the models financially is really sensitive to that, right? So if you pay too much for a palliative care program or a primary care management program or these kind of things, it makes it really hard to save money to justify that additional cost, never mind have kind of net cost reductions. And so in some of our models that were the biggest financial losers, it was because, we had paid specifically primary care and oncologist physicians in 2 different models, a lot of money to do additional care coordination. And even though in primary care, we actually didn't see any change in cost, but in oncology, we saw a lot of change in cost and a decrease. It just wasn't enough to offset the additional payments that we were making. So these upfront additional costs are, hard out-of-pocket costs that are real. The savings obviously are more complicated and have to be accrued over time. Secondly, I would say this benchmarking issue, it is a super technical issue, but, as Lynn said, it's the price that you're setting. And so how accurately you're able to set a price in advance, definitely has a huge impact on the financial performance of a model. As you can imagine, all the participants want you to set the benchmark in a way that's favorable to participants, right? So there's nobody who ever called me and asked me to lower a benchmark. It was always some really technical reason that it should get higher. Which again is not surprising, right? But as you listen to stakeholders, you tend to take that feedback, but the practical result is these things creep up a couple of percentage points above where they probably should be. And the third is adverse selection. Part of having models be voluntary is you allow people to opt out of them. Sometimes you allow them to opt out every year. Sometimes you allow them to drop certain patients or episodes or things like that. And obviously, the more that you allow people to select out, the more likely it is that the only people who are staying in are the people who are making money, and all the folks who would have lost money are basically opting out and going back to the fee-for-service system, right? So in those models, it's almost by design, the model almost has a hard time ever making money. And again, that doesn't mean those aren't good models to do. They may be the right place to start some of these changes. It's just that when those are high risk with certain model designs, eventually you have to move to a different model design. Mandatory is one way to do it. There are other ways to do it about penalties for dropping out and things like that, that kind of keep everybody in the model. Because if you're always letting the folks who aren't doing well go back to fee for service, you'll never get to a place where you're generating, real meaningful savings for the system.
Yeah, thank you. That's really helpful. And as you think about your time at CMMI, Brad, I'm just wondering which of the models are you most excited about, or what do you think has the most potential that developed under your time there?
Yeah. So a couple of things. I mean, so one, it's always interesting when you're coming in kind of in the 3rd, 4th year of an administration, because you don't know how long you're going to be there. And I'm glad I approached it that way, obviously, in retrospect. But, so really what you do is you pick up on the work that's already been done, right? And you say, hey, what's kind of being worked on and what is here? We're kind of within a reasonable period of time. I can kind of get it from one place and get it across the finish line. So there's a number of things we did around demo for lower insulin prices. We pushed direct contracting forward. I mean, the thing I was most excited about was this direct contracting geographic version that we did, which was essentially, what we saw is that the Medicare fee-for-service beneficiaries who needed care the most and had the most fragmented care were not the most likely to be in ACO models. They were actually not likely for many reasons to be aligned in those models. And so the concept was to make sure that, essentially every Medicare fee-for-service beneficiary had some level of care coordination. And I think this would really benefit those who had the least, honestly. I think we did a really good job designing the model. We did a lot of stakeholder feedback et cetera. I think it's a big change to the current system. And so, Liz and I have talked several times, and I think with, good reason, she wants to spend a few months like learning more about how we thought about it and figuring out what we're doing. But it would have, in my mind, been, and I think Liz wrote about this when she was at the Commonwealth Fund. I mean, one of the most fundamental changes to fee-for-service in the entire country, because we were essentially, in a couple of cities going to eliminate fee-for-service on a standalone basis and move everybody into some kind of value-based arrangement. And so, I don't have a strong opinion. Obviously, I think we did a good job designing the version we had, but I think this concept of how do you tip the whole system forward? Because eventually we have to get to a point where it's not, people selectively doing it for 10 or 15%. Eventually you have to do it in mass. And, the GEO model was the first attempt to really, again, not in a big way, but in a few cities in a big way, really kind of push things across the finish line to really change the paradigm. And whether it's through that model or a future version of that model, I think with the 10 years of learning we have, we need to do that either in some specialty or in some geography or in some way if we're really going to kind of continue down this value-based journey in a real way.
Yeah, that makes sense. And in that direct contracting model, provider groups take full accountability, it sounds like, for a population, financial risk and accountability for the outcomes. Could you tell us a little bit about the opportunity or where you see palliative care fitting into some of those direct contracting models?
Yeah, so I think, it makes sense from the federal government's perspective to, I think, do models that are as big as possible and that give large populations of risk to other to either specialist groups or primary care groups, et cetera, ACOs, hospital systems. But within all of those models, the way that you're going to drive the most clinical cost savings typically is around the most expensive patients and the patients with the most chronic diseases. And so whether you do that through, a more traditional kind of care management play, whether you do that through, in-home kind of or in-facility palliative-based care, I think these kind of things are definitely the biggest driver of the savings. There are other things you can do about shifting site of service and some things that also can make a big difference. But, in terms of, kind of the traditional clinical management, I think everybody knows that, most of the cost savings opportunities in the top 5 to 10% of a population, and whether that's 1 or 2% that you're focused on with palliative care or a broader definition that hits that broader bucket, I think it can be a big sub part of these larger models. And just like in Medicare Advantage, where you see plans and provider groups incentivized to lower the cost of care, a number of the models like direct contracting do that as well. There's also a version of direct contracting for kind of high needs, and Lynn mentioned this as well, which is really focused on groups like palliative care providers, home-based primary care providers, where knowing that the population is different, there's kind of a different risk adjustment system in place, but you can really come in and take risk on that population specifically. And so there's not only an opportunity to kind of, for like the word, subcontract with ACOs and primary care groups, but also to participate directly through the high needs direct contracting route.
That makes sense. And as we think about this audience too, that's, many people here are paid on an RVU model or a volume model or an eat what you kill model, what you bill on. And as we shift more toward this accountability, keeping people healthy and at home and rewarding that, what's your message to the folks listening to the call today as we think about moving from that rewarding volume to rewarding keeping people healthy and at home?
Yeah, I think one, it's more important than ever. And I do believe, despite some of the, maybe lack of savings on some of the models, that, I think value-based care is going to keep pushing forward. And you see a lot of this in Medicare Advantage. I think you're going to see more of it from the federal government on the fee-for-service or the traditional Medicare side. So I think the kind of things that people are doing are incredibly important. And I would, at the highest level, encourage them, to do more of it. I think that the key issue is back to kind of that upfront cost issue and thinking about how expensive is the intervention for a specific patient population, and how do you titrate the interventions appropriately where, you're obviously improving quality, but you also really do have a positive ROI. And I think, probably as many of us have been learning, including me at Aspire, right, over the past, 5 to 8 years, is getting paid $300 or $400 a month for, a big group of patients. It's really hard to make that have a positive financial outcome. Now, for a really narrow group of patients, that's appropriate, but obviously the cost of the intervention has to come down as the patient population gets larger. And so figuring out, where are those cut points, figuring out, how you can leverage virtual care, figuring out the extent that you need, an expensive model of going to the home, how often can you do that for certain patient populations? How can you leverage more mid-levels or even like non-clinical folks or social worker versus an NP or a doctor? I think all those things become really important for making the financial piece of the equation make sense. And so I think my broad encouragement would be, to keep running down this path, but to continue to learn how to, for lack of a better word, kind of titrate the intervention appropriately so that you have a higher probability of having a either neutral or hopefully positive kind of financial return on investment.
Yeah. And along those lines, Brad, with that per member per month cost and even payment rate, the primary care first seriously ill population or SIP model was proposed. I'm wondering if you're able to give us a bit of an update as to where we stand with that primary care first SIP model.
Yeah, for sure. So, when I was, before I went into government, I worked with many of you guys to kind of advocate for a model, similar to this. So, I went in very excited about it. What was interesting is there were some real issues that they were still working through when I was there around two things. One, which is probably not surprising to anyone on the phone, is around the payment rate and the length of the payment and how to increase the chances of a positive ROI. I think there were a number of things in the design around, average length of stay in the program and things like that could help address this. The bigger reason, and the reason that we actually never rolled it out while I was there, is an operational reason, which is the idea for the model was that CMS would identify a set of beneficiaries who might need this kind of care, and that there would be some kind of outreach process to these beneficiaries. And figuring out how to do that outreach process in a way that was likely to end up with a high number of people enrolled in the programs was very, very complicated. So, for example, when I got there, the plan was that, they were going to subcontract out to like a third party who was basically going to cold call patients. And the patients were then going to try to tell them the number of the local provider who would then cold call them again to get them to enroll. Right. And I was just like, that's not going to work. And so like a lot of what they were working on while I was there is like, could you give these at least to the provider to have them reach out? Like, is there a path where you can take warm referrals, although that raises like control group issues, right? So there were like these really practical things about how you would operationalize it, where kind of when I got there and just had them walk me through, I was like, there's no reason to launch it if that's how we're going to do it, because the chance of success is so low. And I'd rather us figure out how to increase the odds of it being successful before we roll something out, because I think that's better for the field long term, because a big pilot coming out that doesn't work probably doesn't help anybody. So, there was progress being made on that. Transparently, without COVID, we probably would have solved it while I was there. With COVID, honestly, it kind of didn't bubble to the very top of the list. And so, hopefully there's a lot of people there who are really passionate about it. Hopefully it's something that Liz will pick up and look at. But the issues were really operational. And I would think to the extent that, you guys have feedback on creative ways to solve that and still leaving like a reliable control group in place, you should definitely think about presenting them back, because I know it's an active conversation.
Yeah, no, thank you. Thank you for that update, because I know a lot of us were very anxious to see that roll out, and those operational things are a make or break kind of deal for a program like that. Brad, as you look back to the roles that you have had in advancing palliative care, you were the founder and CEO of the largest palliative care company in the country and helped deliver palliative care to areas that didn't have it, towns and areas that never had palliative care providers before. And then in your role at CMMI. And as you think about this audience, I'm just wondering, as you put together your past experience in innovating and disrupting palliative care in a good way, putting it on the map, what advice do you have for the people on this call?
Yeah, so I mean, the thing I was amazed at every day with what we did at Aspire was just how big of a difference it made in the people's lives, right? So I think the idea that high touch, very personal care that's based on building a relationship with people, understanding their goals and helping them achieve those goals, is just tremendously important and a tremendously important part of the healthcare system. I think, the thesis behind Aspire when we started it was there were many folks, including several who are, I'm sure, on the phone today, who were, outrunning these programs in really high quality, but, relatively small ways in different geographies. And typically the limiting factor for them had been the financial reimbursement, right? And it was because there wasn't really the financial reimbursement, they'd had a hard time being able to scale. Yeah. And so really, what we focused on at Aspire was trying to figure out how to create kind of that positive reimbursement mechanism with the idea that if we could solve that, there was a lot of good care to be done and it could be scaled in a unique way. And I would say at Aspire, at least, at the point that kind of, we sold it to Anthem and I exited, I think we were halfway there. So I think like what we had figured out is we had figured out how to save money on folks who were at the end of life. And we had really significant savings. And I think we had a tremendous impact on their quality of life experience. I think the part that we were solving towards kind of the end is how do you think about this other part of the population that doesn't pass away within a year? And I think, many of us had thought that would be 10 or 20% of the population, but it turned out in practice that was more like 50 or 60% of the population, and turned out to just be something, much more important than maybe we originally thought. And I think a big part of that was either thinking about how to narrow the population or more likely how to titrate the intervention, right? So, at the end of Aspire, we were spending a lot of time, thinking about, and ultimately, when we sold to Anthem, we ended up doing a thing with Anthem where we served the top 5% of members, but with a highly titrated intervention. And so I think this issue of kind of, who do you target? What can the cost of the program be when you target them? How do you flex the intervention up and down? How do you have a financial reimbursement structure that corrects for that? And again, I think we've all learned a lot over the past several years around this. And I think it creates a tremendous amount of opportunity. But I think, if I was starting or trying to expand my program, I would just start from knowing that this is challenging and difficult and that it has to be titrated. And if you go in thinking you can get paid $300 or $400 every month for every patient, that's probably not the right way to start, right? But to be fair, I don't think any of us knew that 7 or 8 years ago, right? And so we've kind of learned that. And I think that's kind of the next journey for palliative care and kind of more broadly this complex care kind of in-home management piece is how do you titrate it at a way that continues to maintain the quality, but has a positive ROI.
Thank you. That's terrific, Brad. And thank you so much for what you've done for the field and what you are continuing to do. I'm going to open this up now to our panelists. I'm going to start with Amy Kelley, who's got some questions on cost savings and along the lines of what you were just sharing with us. Amy?
Yeah, hi, Brad. Thank you so much for joining us today. I just really wanted to follow up on the last point that you were talking about, the very strong evidence for the portion of the population who is at the end of life in terms of both quality and cost savings, and what all of us know from the care we've provided, that a whole lot of people who need these services are those folks who are not right at the end of life. And so you mentioned this a little bit, but I wonder if you could just say a bit more about, programs really trying to tackle that issue. And part of it being that you don't know which group your patient might be in when you first meet them. And certainly the data that help us sort out who might be in which track and how to titrate services along the way with those data limitations as well.
Yeah, maybe I'll say a couple of things here. So I think from and these are high level comments, but the algorithms are not very good at getting a broad group of patients where the vast majority of people are in the last year of life, right? I think at least when we were working on it, if you had a really good one, you could get somewhere between maybe 40 and 50%, but then you were cutting it like 1 or 2% of the population, right? And if you got to 5 or 6%, you were dropping down pretty rapidly to more like 20, 25% of the population would pass away within a year. So I think, we did see, more success from warm referrals where, somebody had put eyes on a patient and felt like they're appropriate. But even there, it depended on the doctor and which kind of patients they were sending, and there was still like a pretty high level of variability. And so I think, programs have to assume that they're going to get, a mix of different kinds of patients. And so I think a lot of it has to be, thinking about a couple of things is, you definitely have to be able to titrate the intervention up and down, both based on the patient, but also over time, right? Different patients may need different things over time. And then I think the thing that, we were thinking about a lot is just what's the right reimbursement model for that? Do you take like a lower average cost across the whole population? Do you have different kinds of costs for different people in the populations? Do you have like some like pretty low base cost, but for your face-to-face visits get paid a higher cost? I mean, at the end of the day, the question is just how much do you get paid for each patient, but how do you structure that in a way that appropriately aligns the incentives? And so I think that's an area where there's a lot of thought, I think good thought occurring across the country. I'd say two other things that are very specific. But there's, a number of companies who are doing what I'm going to call kind of like one-time visits on urgent care situations in the home. This is folks like Dispatch Health and other folks like that. I mean, I think you're seeing like tremendous ROI in those scenarios, right? They're getting paid, a whole lot for one visit. Or maybe like one in a follow-up. But if you're identifying people who have sniffs about to send to the hospital if you don't show up, right, that is a clear kind of high ROI. So I think, we would have never thought at Aspire about, that episodic of interventions, but I think it turns out some of those episodic things can be, very, very powerful from kind of a, overall ROI perspective. The other part, and, I wish this wasn't true, and maybe if I'd been in the government longer, we would have fixed it, but is the truth is for these patients in Medicare Advantage, look, there's another play for the Medicare Advantage plans, which is not just on the cost reduction side, but it's on the revenue lift side. And, many of these in-home providers of care in Medicare Advantage are not just decreasing costs, they're appropriate, or probably debate about appropriately, but they're risk adjusting patients in a way that results in increased revenue to the plan, and that has very tangible ROI. So transparently, one of the things we're thinking about at Aspire is if we kind of went more upstream, how do we add that to our service offerings? I'm not saying that that's a good value add for the system writ large, but it was important for the plans were going to have people doing that anyway. And if we were already in the home and we could do that, it increased our value proposition to the plans in a way that made our model more sustainable for that population. And I think you see, many other kind of home-based companies who actually started their models really around the risk adjustment piece and then over time have moved towards the clinical care. I think for lots of reasons, you could imagine the clinical care being better when you go from the clinical care into the risk adjustment, right? But I think just, knowing that there's value, at least in Medicare Advantage on both those sides is important. How much value should really be there around risk adjustment is probably a big policy question, not for here, but it's the reality of the current situation that we're in. And I think something people should be thoughtful about.
Right, that's terrific. Let's turn to Janet. Did you want to have a couple of questions, Janet, on swim lanes and accountability and primary care versus palliative care?
Yeah, sure. Hey, Brad, it's great to see you again. Thanks for being here. So as you know, the majority of palliative care delivered today in this country is through consultative services with delegation to primary care for treatment decisions, often medications and disease management. Do you envision a shift in accountability to palliative care for those same kind of primary care needs in a value-based model?
I think it's really going to be situation by situation. At least like our experience at Aspire was that every primary care doctor was different and every facility was different in terms of what they wanted. And I think, the approach we took, and I think it's probably the best approach, but, others may think about it differently, is that being flexible was kind of best, right? And being able to, be that quarterback when either the patient or the primary care doctor really wanted you to be that quarterback, or being able to be, almost like consultative or another specialist when they wanted you to be that. I think being able to go between both is best, because I'm not sure that there are, writ large rules about when somebody wants one or when somebody wants the others. There are probably patterns to it, right? Like, for example, in rural areas, there are fewer people going to the home. And so maybe it's, more value to kind of be the quarterback there. It's harder to get into a center. In facilities, if you're also being the medical director, maybe they want you to kind of quarterback the whole patient. So there are different settings of care where I think, one may be a little bit more prominent than the other, but our experience was that it really depended on the primary care physician. It really depended on the patient's mobility and ability to see other providers, and that us being able to, flex based on the individual patient circumstance is what, created the opportunity to serve the most people in a way that was helpful.
Well, you may have kind of answered my second question, which was really around rural care, where there's a dearth of primary care providers. So how do you get a value-based model really working in those areas? And as you know, there's kind of a dearth of palliative care providers in those areas. There's a lot of telehealth, I think, going on now, which has been great, but it's really challenging in people that live so far apart and don't have access to the same kind of care as they do in metropolitan areas. Any thoughts about that?
Yeah, so I mean, we didn't plan this, but like this is actually the next kind of thing that I'm going to end up focusing on is something around rural healthcare and value-based care in rural areas. And I think, one of our going in assumptions around it is, you're not going to add new providers to these geographies necessarily, right? The idea that all of a sudden in some of these rural areas, like another NP or another doctor is going to show up is maybe not, that realistic. And so I think a lot of it's about, how do you leverage the providers who are there in the most efficient way, and how do you wrap around them and bring other resources to them in the most efficient way? And I think, for palliative care, it kind of depends on what kind of providers you have in the community. So I think being able to have additional specialists or higher level clinical folks who can wrap around home care agencies or home health agencies who are already in the home, whether that's via telephone or televideo or whatever it is. I think that can be, very high leverage, whether it's thinking about folks who are coming into clinics who can access specialists without having to travel, an hour or 2 hours. I think those kind of things are really high leverage, but at least our assumption has been, having more providers or dramatically changing the provider footprint in these rural communities is pretty hard. But thinking about how to empower them and how to provide them additional resources and wrap around them is probably a pretty big opportunity. And I think that's probably true writ large, but I think it's also true for palliative care specifically.
Thanks.
Caitlin.
Hi, Brad. Thanks so much for your time today. Many of us on this session today are frontline clinicians or are running palliative care programs, and we're just kind of wondering what kind of advice you have for those of us on the call that are doing that kind of work.
Yeah, so it's interesting. So my brother, the way I got interested is my brother is a palliative care physician out at Stanford. So he was in town this weekend and we were chatting about it. So, the thing I always encourage him is, I think understanding the business side and the financial side, at least for people who are running programs, is just so important because I think the more that you at least are aware of that, it doesn't mean you have to change what you're doing or compromise what you're doing, but the more that you understand the context in which other stakeholders who affect your daily work are thinking about it, I think the more likely it is that you can serve more people and scale the program. And so, I think it was really, interesting as kind of we went through the Aspire journey together as I was learning kind of the business side and he was, going through his training on the clinical side and thinking about like where those things naturally adjoin each other really well. And then also, transparently where they produce like certain kinds of tension between things, right? And I think, the more that folks can be exposed, especially leaders of programs can be exposed to both sides of that, I think the more likely they are to help, appropriately balance those tensions in the context of their specific setting.
Yeah, no, that makes really good sense and is very helpful, I think. And I think there's some Q&A coming through as well. Interesting questions around right-sizing the timing of these models. You mentioned how it's can sometimes take 5 to 7 years from planning to even implementation. And some of the questions coming in have to do with, can we fail faster, kind of set aside the things that aren't working as well, learn what's working, but also what's not working and stop doing it. Also balanced with this idea, should we be studying things a little bit longer, especially when we think about people with social determinants of health challenges or a lot of the really important challenges we have to face and solve around health equity and disparities. And so how do we kind of, just like you right size, balancing clinical with business, how do we kind of right size the timing of these models in terms of looking at them long enough so that we can learn enough, but also retiring what is not working, and then also fitting in, those really important non-medical needs of our patient populations we're serving.
Yeah, for sure. So a lot of this, and I spent a lot of time with this and worked with this woman, Renee, who runs the evaluation group at CMMI on this, is really there were kind of two core issues, and at least I think we got them on a path to being resolved. There's still a little bit more work for Liz to do, but we made good progress, which is the way that it currently worked was that the program would start. They would typically get 3 to 6 months of claims run out, typically after like year 2. They would then, run like a full analysis of like the overall success of the program. I'm like maybe exaggerating a little bit here, but it's like directionally right. That would come in like by the end of year 3, the end of year 2 or the start of year 3. They would then start to think about changes to the model. They would then have to go through the approval process for the changes. And maybe by year 5, they would have changed the model. That was just like the actual timeline that was occurring, right? And so when I was there, and again, I think I had the advantage of being there long enough to have seen these things where it's like, oh, that's not a one-time thing. That's the pattern of how it works. But, we really changed 2 things. Number one, Renee basically went back to all of the contractors and said, look, 90 days of claims run out after the first year. And you have to have the financial analysis done within 90 days after that. So in other words, she was moving, and I think had moved by the time I left, all the contracts to where for every single model, maybe not the whole analysis, but the core financial analysis would be done by June of every year, right? Which is a huge change. And that the way the contracts were going to work is that every year you did the financial analysis. And then if you wanted to do additional things, you would then identify those after June and spend more time going in deeper on those specific things, right? That would be more helpful. But you would at least have the other piece, and this did not get done, and Liz has to kind of get this one across the finish line, was the process that got set up early on, which again may have been the right process early on, was that you had to go through the same internal government process to change a model that you did to start a model, which was really like a year-plus process. So, I had to take it to SEMA and then to Alex and then to the budget people and like all these different people. And like, even though they were all trying to be helpful, like there's just no way you can do that faster than like, 6 months or more, right? And so kind of what we had designed, but again, the Biden folks have to figure out how to implement it, was kind of like a different process for changes, especially when the changes were going to save money, where, essentially, if you could get the actuary to write a memo that said, hey, by fixing this benchmark thing, and I'll give you like an absurd example here in a second, that'll be surprising, but is by fixing this benchmark, the program will increase its savings. That basically that could get approved in like a 30 or 60-day period, so that it could actually go into effect for like the following year. So it was going to be a really fast timeline, but the evaluation data comes out in June. You're making decisions really quickly in like June, July about what you want to change. You're trying to get that approved in like, August, September, because you normally have to tell people about the changes in September, October for the following year, right? And so we were trying to kind of move to this, modification cycle that could really be, again, you're still 1 year delayed because you're changing for year 3 to year 1 things, right? So it's still not perfect, but I think we had made like some good progress around that. And again, I think people were generally aligned in the government around doing that, but actually having people say it's a good idea and actually making it happen in that time frame are different. And I think that's kind of, one of the challenges that we leave, Liz with. But the other thing I'd say, just to give you an example of how bad it was, is there was like this joint model for comprehensive knees and hips. And we had known for 2 or 3 years that the baseline was wrong. But it was only going to save like $50 million a year fixing it. It was a mandatory model, and so it had to go into a rule. And literally for like 2 or 3 years, nobody had prioritized it high enough to get into the rule. And so we were just still doing it the way that we knew was wrong. And we're just like, it's like and so that's just like the nature of it. And so obviously, like, that's got to be changed to be able to fix these things fast enough to be able to innovate more quickly.
Wow. Yeah. And in the minute we have left, just before we conclude, I wonder if you could just touch on hospice and what you see the role of hospice is going forward.
Yeah, I mean, I think you can think about, I mean, obviously hospice is really important, right? And, you know, I mean, for many people, like including my family, and it's one of the things that has touched many people's lives in like very different and incredibly impactful ways. And, you know, obviously to you guys who work in every day, but it can be the most meaningful time of people's lives in a lot of ways. So I think it's incredibly important. I think from like the future, I think it goes back to this idea of like titrating interventions, right? So to the extent that, you know, hospice is not a, you know, $400 or $500 a month intervention, but maybe a $4,000 or $5,000 a month intervention, right? Thinking about when and for whom and how long that's appropriate. But this whole idea for this, you know, complex population having the right level of intervention at the right time becomes really important. I mean, and you guys have all been part of the research on this, right? Like that $4,000 or $5,000 number may be too small for the last 30 days of life, right? It's probably too big for somebody who's living in a nursing home for a year and a half, right? So, you know, figuring out kind of how you titrate these things appropriately, I think is the theme. And I think, you know, whether it's like with more carve into MA or just changes to the fee for service program, I think you're going to continue to see, just like you have with like the U-shaped payments and all of that, you know, more of the push around how do we appropriately titrate and reimburse the intervention based on where patients are.
Hey, Brad, I'd like to ask you a question about the Medicare Care Choice model, which showed improvements in quality and also cost savings. Do you see a role for expanding that in the future?
Yeah, people were really excited about MCCM. Obviously, it's a really small model. I want to say like 6 hospices had like 60% of the patients or something like that. That may not be exactly right, but again, I think it was a model that was going well. The data was a little bit early because it was small. And there was also this question of like, how did that and the CYP model potentially come together, and how did like high needs DCE come together? You know, one of the challenges for CMMI kind of writ large is there's a lot of models happening and it's like pretty confusing to people. And so, you know, again, we'll see if Liz does this, but I think there was an idea that maybe having like fewer bigger models was better than having like a lot of different flavors. And so there was this question about kind of how does MCCM, CYP if it happens, and high needs direct contracting complement and come together. So I think you're going to see a continued focus in this area at CMMI. You know, which combination of those 3 things it's through, I think is still like an evolving question.
Thank you.
Terrific. I'm going to hand it back to Len.
And I'll do my best to unmute myself. Brad, again, thank you so much for your candor and your insight and your service. Really appreciate you taking the time and everything you've done for the palliative care field. Dana and the rest of the panel, thank you so much for investing so much of your time and coming up with good questions. And I think we got to almost, if not all, questions that came through. So thank you to the audience for sending them through. And finally, I would just like to say the recording of this, as always, if you've registered, you'll get an email saying the recording is ready, and it's podcast and it's video. So we had several questions about that. So if you're on the list, you'll get an email telling you, and feel free to share that with whomever you'd like. And finally, you know, we're able to keep doing this because people are benefiting from it. So if you know others that might benefit, please send the link along, let them know that this is happening, because as we grow the volume, we have more opportunity to pull more great people in like Brad. So thank you, everyone. Have a fantastic day, and hope to talk to all of you again soon.
Thanks, Brad. Thank you, everyone.
Thank you.
Thanks so much.